Hey guys, today we're going to be talking about the extraocular muscles and hopefully clear up some of the confusion that seems to go along with learning these muscles. Um, One of main points of confusion are that there are a difference between what the muscles actually do in isolation and what they what we do to test them, right? So what I mean is when I refer to anatomical is what they are doing in isolation. If you were just to pull back on the muscles, what effect they actually have in the eye, and what I mean by clinically is what we do to test them, right? So what we ask the patient to do um, to test those muscles, um, and that's really odd, right? That's odd that what we ask the patients to do to test those muscles are different than what the muscles are supposedly doing. Um, but after this talk, hopefully we'll understand it a little bit better. So what I've done here is here's the outline of the way that the video is going to go, and since everyone's busy, you can click on whichever section you'd like. If that's if you only need help on a specific section. So we'll start off with an introduction, what we're doing now, and you can click on basics if you don't want to listen to me explain the outline. Just get right into the talk. The basics will be what we're going to be talking about for the difference between anatomical and clinically on a basic level, but a little bit more in depth than what I've already talked about. Then we'll have a discussion about the orbits, and we'll explain that and the orientation of the orbits and how the eye sits in them, because understanding that is important for the rest of the talk. Next, we will have a discussion about the anatomical, right? What I've already mentioned is what the muscles are actually doing, what their functions are. We'll start off with the recti, the four recti, and then we'll go to the two obliques. And then next we will talk about what would happen to the eye if we had a lesion of the cranial nerves that innervate these recti and obliques. The next section will be clinical. Again, that's what we do to test the muscles and why we do that. And again, we'll start off with the recti, then we'll go to the obliques, and last we'll end with some tricks. And what I mean by tricks are just some different ways of thinking about it or drawing the diagrams that might help remember the differences between the two. They help me at least. Lastly, we will have a quick discussion on the internal and external rotation of the eye, and I'm leaving it off to the end because I think it is sort of necessary to understand all of this stuff before we get there. And then we will sum up and end, obviously. Okay, so the first thing we want to talk about are what I mean by anatomical and clinically, and what diagram you may have seen before. It's sort of floating out there that I've seen different textbooks use. So what I've just done is I've drawn an eye with here's like the pupil, and we're looking at it on sort of a coronal slice, looking straight on. And let's say this is the right eye, so this will be the lateral aspect of the eye, and this will be the medial aspect. And then we will draw 6 arrows in the direction of the muscle's function. So here's the medial rectus, here's the lateral rectus, and then we'll draw the other 2 recti, the superior rectus and the inferior rectus. And before we move on, I just want to stop here for a second and show that all the recti are sort of doing what they say they're doing, right? Medial's in, lateral's out, superior's up, and inferior's down. The 2 obliques, on the other hand, the inferior is pointing up and the superior is pointing down, and I think that's one of the first points of confusion, right? Is that the superior oblique is down and the inferior is up, which is a bit bizarre, but makes perfect sense when we actually look at where they're inserting in and where their origins are. So that's anatomically what the muscles are doing in isolation if we were just to pull back on them. Clinically, this is what we do to test the muscles. The medial and the lateral recti are the same. Those don't change, but the other 4 are flipped. And what I mean by flipped are they're flipped horizontally, right? So these 2 are still elevators, and these two are still depressors, and elevating just means look up, and depressing just means look down, but they're flipped horizontally. So now this becomes the inferior oblique, this becomes the superior rectus, this becomes the inferior rectus, and this is now the superior oblique. Okay, so just, think about this for a second. Like I said, the two main points of confusion are that they're flipped between anatomical and clinical, and that the superior is always on the bottom while the inferior is always on top. So the next thing we will do is have a discussion about the orbits. So the first thing to note is that the orbits are they're symmetric from left to right. Obviously, since our face and skull is roughly symmetric, but it's a little bit different than I think people might expect. If you were just to ask someone on the street what the orbits, what the sockets, the eye sockets look like, I think they would think that if you were to draw a line straight back from the pupil, if you were just to draw a line straight back where the light goes, you could keep drawing and you'd get to the back of the orbit or the apex. But that's actually not true, right? That's actually not what we see. That's not how the orbits are organized and structured. Instead, they are sort of shifted like this, right? And I can sort of prove that to you if you want to look at a skull straight on, right? What we're seeing really is the lateral wall, and the medial wall is sort of hidden from view. If you were to rotate the skull, then you could look straight back and see the apex of the orbit, right? You could actually, if you rotate the skull. So basically, what I've done here, rotating the skull, is basically just looking at the eye socket sort of from the side, right? So this is an MRI, and if we're looking at it from the side and draw straight back, we can see the back of the orbit, which is what we're doing here. But just to show you guys that I'm not making it up, this is what the orbits look like. The eye sort of sits in them like this, right? And that's how I've drawn them here. So why is that important? Well, it's important because the axis of the orbit, right? The axis of the orbit. What I mean by that is dividing the orbit in half like this. The axis of the orbit actually differs from the axis of the eye. And what I mean by the axis of the eye is the way that the line in which light shines through, right? If this is a pupil and light shining through back and hitting the fovea being the sort of center point of our retina, the place of the highest acuity, the 2 degrees in the middle of our vision that's clear, that line right there is different than the line that is lining up the orbit. And just to sort of orient ourselves. So, like we said, this is the eye. Now we're looking at it. If we're looking down on it in sort of a horizontal view, this is, let's say, the apex of the orbit, the center, the base is straight back, the apex. All of the extraocular muscles, except for one, actually come back here. And that's important because if we were to look at a skull, if we were to, let's say we're going to, so what I'm doing right now is I'm tracing the orbit rim, right? Let's say I drew an eye, right? Like something we might see on a patient, right? And this is looking up, this is looking down, this is looking out, right? Or abduction, and this is looking in, or medial, or adduction. What we see is that the center point, the apex of the orbit, like I said, was a bit more medial. But that's really important because most of the muscles come back here, right? This is where they originate from. And if we were to draw a line or a muscle, coming back here and attaching to the inferior part of the eye, if we were to pull back on that muscle, then you can see that it's not going to be pulling straight down you can see that there's some medial direction to it, right? It's not purely depressing, which is getting ahead of ourselves a little bit. Um, but like I've mentioned um, already, there are 6 extraocular muscles, right? 4 recti and 2 obliques. The superior rectus, the inferior rectus, the lateral rectus, and medial rectus, and 2 obliques, the superior oblique and the inferior oblique. Okay, so a couple things. One, rectus. What does rectus mean? Rectus means straight. Um, that's all it means. That's literally what it means, and that's the reason why we see the word rectus in other muscles, right? Like the rectus abdominis and the rectus, I should say, abdominis and the rectus vastus, or um, the femoris, I should say. Um, that just means straight, and that describes muscles that are straight. So these are actually going to be pretty straightforward, which is why I made that point of showing that when we don't have the obliques, they sort of all do what they say they're going to do. Um, um, but the 2 obliques, oblique means sort of at an angle, right? And so those are not going to be as straightforward. Um, another difference, another point that I wanted to make is that all of the recti attach to the anterior side of the eye, and all of the obliques attach to the posterior side of the eye. Um, the recti that attach to the anterior side of the eye have their origins back here, the posterior side, and the obliques that attach to the posterior side have an attachment up here to the anterior side. So the obliques are sort of pulling in this direction, while the recti are sort of pulling in this direction. And that's going to be really important later on when we talk about what they are actually doing. So let's walk through the recti. So I'm going to talk about the 4 recti over here, and I'm going to talk about the 2 obliques over here. Obviously, both eyes are going to have all 6, but just for clarity's sake, we're going to leave them separated. So here, we'll draw the 4 recti. So let's say that this is the superior rectus, right? This is the inferior rectus, sort of diving down behind the eye, right? This will be the medial rectus on the medial side, and this will be the lateral rectus on the lateral side. Okay, the first thing to note, actually, a really important point, is that since they all attach back here at the apex, which we said is over here, so more medially, so that means that every single one of these recti, when we pull back, are actually also pulling the eye medially. So, and that's a good thing, because if we look at what we drew, all of the recti, except for the lateral rectus, pull the eye medially as well as doing what they superior and inferior for the superior and inferior recti, respectively. And that's why. That's why is because they attach back here, sort of medially. So now moving on to the obliques. What I said about being attached posteriorly, right? So they're both attached back here on the posterior side of the eye, but they have attachment points on the anterior side. So I just divided up the eye right here, right? And we're looking at the posterior side, and this is the anterior side. And this guy right here, we'll say is the inferior oblique. It's actually attaching to the medial floor of the orbit. It's the only extraocular muscle that doesn't come all the way back here. You can see the 4 coming back, and then this one comes back as well. This one's very bizarre. This one's the superior oblique, right? And the superior oblique winds around this trochlea, right? And the trochlea just means the hinge of a pulley, and it winds around here. So even though it's originating back here, and the belly of the muscle is running on the medial side of the orbit, the tendon of the muscle wraps around this trochlea and then dives back. And a way of remembering this is that the superior oblique, this is the reason why we call it the trochlear nerve. The nerve that innervates the superior oblique is called the trochlear nerve, and that's because it has this trochlea, or this hinge that it wraps around. And that's really important because now we have an attachment on the anterior side and an attachment to the eye back here on the posterior side. So why is that important? Well, it's important because now whatever we're doing to the eye, we're doing to the back of the eye, is going to be flipped. It's going to be reversed to what we see the eye actually doing. And that's just a function of the fact that we're seeing the anterior side of the eye. So if we were to talk about the superior oblique, whatever we're doing to the posterior side of the eye is actually going to be flipped. It's going to be the opposite to the anterior side, or what we're seeing the eye do. So the superior oblique is going to be pulling the back of the eye up because it's on the superior side, right? Because it's superior oblique, which means that we're going to see that the front of the eye going down, or looking inferior. It's also going to be pulling the eye medially, right? The back of the eye is going to move medially, but that means that the front of the eye is going to be moving out laterally. And that's why we say that the superior oblique is responsible for the down and out look. Okay, the inferior oblique is actually very similar, except that it's on the inferior side of the eye. So now the posterior side, what it's doing to the back of the eye, it's going to be looking down because it's inferior, which means that the front of the eye is going to be looking up, or superior. Again, it's attached to the medial side, so it's pulling medially, but it's pulling the back of the eye medially, so it's pulling the front of the eye out laterally, which is a good thing because that's what we see. We see the superior oblique looking down and out, and we see the inferior oblique looking up and out. So that's the reason why these are flipped, right? That's the answer to the first mystery, right, of why the superior is down and inferior is up, is because they're actually attached to the back of the eye, and what we're seeing the eye do is the front of the eye, so it's reversed. So this down and out leads us to another important point. If we were to lesion the third cranial nerve, or the ocular motor nerve, which are responsible for these four, they're responsible for every single ocular muscle except for the superior oblique and the lateral rectus. If we were to knock these four out by something injuring the third cranial nerve, then only these two muscles would still be functioning and the eye would look down and out. So if someone's looking down and out, you want to be suspicious of a third cranial nerve lesion. So that's the third cranial nerve. The lateral rectus is innervated by the sixth, or the abducens, and it's called the abducens, and that makes sense, right? Because we're abducting, we're abducting, and the superior oblique, we already said, is innervated by the fourth cranial nerve, or the trochlear nerve, and that's because it has a trochlea, right? It has that hinge that it wraps around. So that's the reason why these things are called what they are. And so I think that this is actually pretty straightforward. If you need to listen to it again, you can obviously go back to the table of contents and click on the anatomical section. But now we're going to move to the clinical. When we ask a patient to look down and in, we are testing the superior oblique, even though we just showed that the superior oblique is predominantly a down and out muscle. Okay, well, the reason for that, again, is axes. So if we were to draw the axes again, if we were to show that, okay, this is the axis of the orbit, right? And that differs from the axis of the eye, the resting eye, I should say, right? That's very important. It's the resting eye. But in addition, though, like I said, this is the resting eye, but the reason why I had to specify that is because the eye can move, and when the eye moves, the pupil moves as well, and the fovea also moves. So if we were to, look medially, we could rotate this axis, and we were to look laterally, we could rotate the axis out, and so the orbit doesn't move. So this axis is going to stay put, but the axis of the eye is free to move. So let's talk about what happens when we do move. If we move the eye, if we look out, let's say we were to move the eye out, so now the pupil's over here and the fovea is back here. Now what happens is that the superior and inferior rectus that were over here, right? Now they've shifted over here. The eye has sort of moved between them, and the attachments are now sort of in line with the axis of the orbit. So what happens now is that now it can pull, when it pulls straight back, because the attachment back here is not changing at all, obviously, right? I mean, this isn't moving, this is moving up here. So now that we've looked out, we've sort of moved these attachment points on the eye over here, and now the lateral rectus and the inferior rectus actually act even more strongly as a superior, as an elevator and a depressor, respectively. Because when they were over here, they actually had some medial action, right? But now when they're in line with the orbit, now they're a pure elevator and depressor. I'm not going to talk about the lateral and medial rectus and what happens when we look in or out, because they're the same both anatomically and clinically. But the superior and the inferior rectus do change, right? And that's the reason why, because when we look out now, we're lining up those muscles with the axis of the orbit and the axis of the eye, I should say, as well. Okay, so that's in one scenario. That's what happens with the recti. And that's actually a good thing as well, because what we see when we drew this diagram is that we ask the patient to look out and up, and that's the reason why, is because when we look laterally, we're sort of isolating those muscles. And that's our general goal. That's our general goal for clinical, is we're trying to isolate the muscles so that in isolation, these muscles might do this, but it might not be possible to isolate them by asking them to act in this way. So, okay, so what I mean by that is that let's say we did have a problem with the superior oblique, and we asked the patient to look down and out. The patient could still use their inferior rectus and lateral rectus to move the eye in this direction, even if the superior oblique was injured. So that doesn't really help us at all. But looking in and down does, and I'll show you why now. So we talked about the recti over here, and now we're going to talk about the obliques over here. And again, all 6 would obviously be on each eye, but just keeping it separated. So again, the obliques attach on the posterior side. Let's say that this is the inferior oblique, and this is the superior oblique wrapping around that trochlea. Right? Okay. So now let's say that we were to move the eye. Now instead of moving the eye out, we were to move the eye in. We were to look more medially. Now what we see is that the axis of the eye, this will be the axis of the new eye, meaning the new position of the eye. Now the axis of the eye is more in line with these oblique muscles. And now what we see is that when we pull back on this, let's say we pull back on the superior oblique, now what can happen is it pulls the back of the eye up, which means the front of the eye is looking down, but it pulls very strongly in this direction because now it's in line with this new axis. And because of that, when we look in, the obliques are actually the primary elevators and depressors. The superior oblique obviously being a depressor, and the inferior oblique obviously being an elevator. But they're actually the primary muscles of depression and elevation, which is a good thing as well, because we've drawn it that way here, right? We've drawn, when the patient looks in, if they were to look up or to look down, that isolates these 2 obliques. And that's because now we're sort of putting those muscles in line with those axes. So now that we've talked about the anatomical and clinical, now I want to, we've talked about those 2 for all 6 muscles, but we sort of left out the actions of the muscles on internal and external rotation. Um, and So there's a couple points to say about the internal and external rotation. One is that if it was a pure internal rotation, let's say we're looking at this eye, okay? And it's in the resting position now, okay? So ignore everything else except for this blue line, the pupil, and the um, fovea back there. So now we were to purely internally rotate, meaning that the top part of the eye is going to be moving in, but it's going to be moving sort of uh, along this axis. So essentially what I'm saying is that the eye is going to rotate, but this line right here is not going to move at all. So the light, actually, it doesn't change the way that the light is hitting the back of the retina if we were to rotate. So that's one of the reasons why it's sort of a smaller point, is because if it was pure internal and external rotation, then the way that the light hits the fovea shouldn't change, because this axis is staying still while the eye is rotating around it. But for completeness sake, let's talk about it. So I think it's important. I think it's useful to talk about the internal and external rotation when the eye is either lateral or turned medially. So this was our diagram for the eye looking laterally, right? So when we look laterally, we orient the axis of the eye in line with the axis of the orbit. And now, like I said, the recti are the primary depressors and elevators, but the obliques are still like this in this direction, like I've been drawing multiple times, but you can see that this is perpendicular to this axis. And so now these guys are the primary rotators. So the inferior oblique right here is pulling the bottom of the eye medially, so it's actually externally rotating. And the superior oblique is pulling the bottom of the eye in, the top of the eye in, and we call that internal rotation, which is actually different when these obliques are in line with the axis of the eye. So when the axis of the eye is in line with the oblique, like I said, these are the primary elevators and depressors, but the recti are still there, and the recti, see this? The recti pull back like this, and now these guys, should have drawn it in the same color, just to show that these guys are actually now perpendicular. So this is getting really messy, but you can see that this is now perpendicular to the axis of the eye, and now these guys are the primary internals and external rotators. So the superior rectus being on top is going to be pulling the eye in, and the inferior rectus being on the bottom is going to pull the bottom in but the out, so that is the external rotator. Okay, so this is getting a little bit messy, but I think it's worthwhile to talk about anyway. Lastly, we will talk about, like I said, that we'll talk about some tricks, some different ways of thinking about how to test the eyes. So when I drew the outline, I said I was going to talk about it before the internal and external rotation, but I got a little bit ahead of myself. But when you click on the links, it'll go to the right section. So the outline's a little bit wrong, but it shouldn't be a problem. So this was the way that we started off the talk, drawing the clinical, right? And this is a way that I've seen drawn multiple times. But I actually think that there may be a better way of thinking about it. So let's say, so what I'm going to do right now is I'm just going to redraw this anatomical map. Okay, I'm just redrawing. It's just a bit messy over there. So this is exactly like it looks over here. But why I am drawing it like this is because if you remember this, if you remember this diagram, then you can actually get everything from this. You can get both the anatomical, because that's what is sort of the standard drawing of it. But you can also get the clinical by thinking about the eye as a dynamic object. So when the eye is looking when we ask the patient to look medially, all of these arrows are actually just vectors. They're just directions for this eye to move in. And when we ask the patient to look in, we're actually rotating all of these arrows as well. So now the new angle of the inferior oblique is straight up. The new angle of the superior oblique is straight down. And these guys are sort of internally and externally rotating. This part isn't as clear, but this is. And when we ask the patient to look in, when we ask the patient to look medially, you can see that just by knowing the anatomical diagram, you can rotate the arrows in the direction of the eye, and now we get that the inferior oblique is the primary elevator and the superior oblique is the primary depressor. The same is true. It works as well if we ask the patient to look laterally. So now we're going to ask the patient to look laterally, and now all of these arrows are going to move in that direction. Okay, so now we can see that the primary elevators and depressors are the superior rectus and the inferior rectus, right? And now these guys are the primary rotators. And again, this part's not as clear, but this part definitely is. And it's an easy way to remember. If all you need to do is memorize this, then you can sort of think about, okay, now I'm moving medially, so all the arrows are going to move that way too, and now the inferior oblique is a primary elevator and depressor. And that's necessary, that's important, because that's what we do to test those muscles. We ask the person to look first in and then up to test the inferior oblique, and in and down to test the superior oblique. The last diagram that I want to draw is basically taking all these into account and just drawing them a bit more directly. So like basically here's the eye again with the exact same lateral and medial aspect, and basically just saying, okay, now this is exactly what we do to test these things. So when we want to test the inferior oblique, we ask them to look first in and then up, and when we want to test the superior oblique, we ask them to look in and then down. When we want to test the superior rectus, we ask them to look out and then up. When we want to test the inferior rectus, we ask them to look out and then down. And so this is basically a completely new diagram, but if you're going to remember a second one other than this, it might be beneficial to remember this one instead of this, because it sort of gets rid of a lot of the confusion, I think. But with that, we have talked about the differences between the anatomical and clinical. We have talked about why we draw them the way we do, that all of the recti move medially except for the lateral rectus, because of that attachment point on the back part of the orbit is sort of more medial, right? And the obliques are on the posterior side of the eye, but they attach on the anterior side of the orbit, which is why whatever they do to the back of the eye is going to move the front of the eye in the opposite direction. That's the reason why superior is down and inferior is up. And we've also talked about the reason why the clinical directions are different than the anatomical directions, and that's because we're trying to isolate those muscles, and to do that we align those muscles in the direction of the axis as best as we can. And the way we do that, just based on the anatomy, is we either ask the patient to look in for the obliques or out for the recti. And with that, I think that concludes our discussion.